When managing cataract patients, at times we do have these patients who have floppy iris because of the alpha blockers medicines which you have taken. So this is one patient who had similar situation, and as we can see the pupil is not very well dilated in spite of the mydriatic, and this is the fundus photograph, and this is the start of the surgery. And at this point it is obvious that the pupil is not very well dilated, and this is apparently something like 5 millimeters of pupil size, and this is intracameral lignocaine which will aid in dilating the pupil and also managing the floppiness of this iris. And the crucial thing about these kind of patients is that inadequate dilation of pupil causes problem in each and every step starting from the capsulorhexis, because the crystalline lens which is hidden behind the iris has to be well exposed for anything to be performed safely on the lens. And these are the patients who are prone to have iris which progressively gets smaller. At the start it is small, and as the surgery progresses it gets progressively smaller. And the iris is also of the kind that it is fluttery and it prolapses frequently out of the wounds. So overall the surgery is very traumatic for these eyes, and also there is an inherent risk of having a posterior capsular tear because of the poor visibility due to the small pupil. Here we are initiating the phaco, and this is my take on these patients because I don't like to use pupillary expansion devices, because I personally think I'm able to manage these cases properly, and this is my technique which I'm demonstrating. So the key factors here are that you have to maintain a perfect orientation so that you are right in the center for all your maneuvers, and you have to have very good foot control regarding the phaco power and aspiration. If you are in the central safe zone and you have created multiple chops, that means the nuclear disassembly is conducted in a way that you have not 4 quadrants, but you have many more smaller pieces which are carved out by dissecting the nucleus and chopping it multiple times. So here we can see the first pie was pretty small. Similarly, several other such small pies will be designed, and this one key factor is that once these pieces are emulsified, the iris on the other side of the nuclear piece is ready to be devoured. So one has to be very vigilant. The moment the piece is consumed, you have to remain away from the iris towards the center so that the ensuing surge doesn't pull the iris piece into the handpiece. And one has to be very vigilant also about the phaco power to be shut down immediately once the piece is consumed. This will prevent chafing of the iris, which will further cause progressive meiosis if it is not properly handled. So any further trauma to the iris will add to the pupillary meiosis, and there has to be minimal of surge and minimal of fluid turbulence so that the pupil doesn't get smaller. However, in spite of all these precautions, we can see that the pupil is getting smaller, and right now it is something like 3 millimeters in size. However, all of the nucleus has been successfully consumed, and now is the time to remove the cortex. Replenishing the anterior chamber with viscoelastic gel, and this will keep the iris out of the wound and also aid in some amount of mechanical stretching of the pupil. Now it's very crucial to have a T-shaped or a dumbbell-shaped dialer so that the iris tissue can be pushed away and pulled towards the side port so that the underlying cortex or the nuclear material, whatever is hidden behind, is very well visible to us. Some amount of nuclear material, if it is present, can be simply stuffed into the aspiration port, and one has to keep the patience. So as we can see here, the iris tissue is started prolapsing into the side port, and one has to stop the irrigation and deposit the tissue and then continue. Pulling the iris away to peek behind so that the underlying cortex can be visualized and removed. At the same time, this also prevents inadvertent capturing the anterior capsular border or the rhexis border, so that there is no pull on the zonules and one is sure that what he is holding. Iris may frequently come into the wound. This is something which is just inevitable because the iris tissue is so floppy that any fluid current will simply direct the iris towards the fluid flow. One has to continuously push the iris away and look underneath to remove the cortex, and this requires patience, good foot control, and ability to reach out to the reflex switch if one needs to. At the same time, some amount of cortex, if it has been peeled away from the posterior capsule and is lying just underneath the anterior capsular margin, can be left behind to be safely aspirated once we have put in the intraocular lens, which will provide us a very good shield to protect the posterior capsule. So here we can see we have removed most of the cortex. However, there is a sheet which is covering the posterior capsule, and the safer way is to simply polish it so that it is lifted away from the posterior capsule and then it is scooped away into the periphery, and this will leave the posterior capsule exposed for the IOL to be put in without disturbing any possibility of having a posterior capsular capture by our aspiration port. So here we can see the capsule is being polished and the remaining cortex has been pushed to the side. Implanting a hydrophobic monofocal IOL. This has been loaded and pushed into the anterior chamber. The IOL has gone into the bag, and now we have a nice shield for the posterior capsule to be protected, and we can safely go and aspirate the cortex which was hidden behind the iris and also draping over the posterior capsule. Now again, the iris tissue has to be manipulated so as to peek behind and see what is hidden behind the iris tissue, so that none of the cortex is left behind. Obviously, pupillary expansion devices can be used for the same purpose, but it simply causes more trauma to the eye, increases the number of ports, and also adds to leaking and iris manipulation. So if this is possible to be managed without placing the hook, this is what I have demonstrated. Surgery has been finished and the anterior chamber is inflated using BSS. This is the day 1 post-op picture, and we can see the exceptional clarity of the cornea, and this is the day 7 picture, which again shows a normal sized pupil with excellent corneal clarity. Thank you.